Now we can move forward to our next talk, which is on the newer therapies on the horizon for IBD. And to chair this session, we are having Dr. B.S. Satyaprakash, consultant gastroenterology in the Dr. Satyaprakash Center for Digestive and Liver Diseases, Bangalore, and Dr. Sreekanth Appasani, who is consultant in charge in Shine Gastro Center, Hyderabad. Over to you, chairpersons, for the session.
Thank you, and very nice IBD workshop we are having it. I think I must thank the entire IBD PGI team for giving us this Sunday feast, and we are really enjoying every session and every minute. I think Dr. Sreekanth, who is my co-chair, will accept the feeling of what we are going through from the afternoon. I'm very happy to introduce Dr. Edward Loftus, who is going to talk to us on newer therapies on the horizon for IBD. Dr. Loftus is a professor of medicine in the Division of Gastroenterology and Hepatology at the Department of Internal Medicine, Mayo Clinic, Rochester, Minnesota. Dr. Loftus, it's over to you.
Thanks so much. And thank you for the organizers for inviting me. The last time I was in India was about 7 years ago, and that was down in Kochi. It was an IBD meeting, which I thoroughly enjoyed. So it's good to see you all again. And I'm just working on sharing my screen here. And away we go. Okay. So my role today is to talk about what's coming up on the horizon for inflammatory bowel disease. So I'm going to spend my time talking about 4 classes of medication. So here are my disclosures. Most of this is related to consulting or participating in clinical trials of new agents for IBD. I'm going to talk about 4 classes of drugs. The first 2 are biologics and the second 2 are small molecules. We'll first talk about biologics that exploit the relationship between adhesion molecules and integrins. And so if you recall, we've had anti-integrin biologics in the past, and while they were efficacious, some of them were plagued with selectivity issues, resulting in off-target side effects such as PML. And so our current anti-integrins that are either approved or under study are more gut selective. So we, of course, have Etrolyzumab, which has been around for a few years. I'm going to talk about Etrolyzumab, which is an antibody to the beta-7 integrin. So that's just expressed in the gut. And that is a ligand for both E-cadherin and alpha-4 beta-7. And then we'll talk about some of the other anti-integrins. So let's move on here. First, though, I wanted to mention that what's new with Etrolyzumab is that there is a subcutaneous formulation that has been studied. This paper was published, the VISIBLE-1 trial, looking at the subcu formulation in ulcerative colitis. And the design here was that patients received either 2 or 3 open label IV doses of Etrolyzumab, and then they were randomized to either subcu Etrolyzumab 108 every 2 weeks, or placebo subcu, or they were receiving placebo and both IV and subcu. So you were getting either the IV formulation of Vito, the subcu formulation, or the placebo. And what this study showed was that both Etrolyzumab formulations were better than placebo at achieving clinical remission and endoscopic improvement at week 52. Okay, and then VISIBLE-2 was a similarly designed study. This was looking at Crohn's disease. There was no IV Etrolyzumab arm here, but the primary endpoint was met. It was better than placebo for achieving clinical remission at week 52. Some of the secondary endpoints were not met. One that was met was steroid-free clinical remission, but enhanced clinical response was not met. Etrolyzumab, we had a whole bunch of Etrolyzumab data come out at the fall meetings. This was a randomized trial looking at etrolizumab in bio-naive patients. And you can see that the etrolizumab formulation, which is sub-Q, did not meet the primary endpoint of clinical remission. And so this was technically a negative study. You can see that there were some numerical benefits for endoscopic improvement in steroid-free remission. We also saw an etrolizumab trial in bio-experienced patients, and the primary endpoint at the week 14 remission mark was met in that significantly more patients achieved remission at week 14 with etrolizumab than with placebo. However, the maintenance endpoint at week 66 was not met. And so it was numerically better, but it was not statistically significant. So technically, this was a negative study. And then we had, sorry, let me go back. Then we had a comparison of etrolizumab with adalimumab or placebo for UC induction. And these were two separate induction trials, Hibiscus 1 and Hibiscus 2. These were identical trials. And while etrolizumab was better than placebo in one of the trials, it wasn't in the other. And the pooled etrolizumab results against adalimumab were not statistically significant. And so this was also a negative trial. And then finally, we had an etrolizumab versus infliximab trial in patients with moderate to severe UC. And you can see that the primary endpoint was not met. So we had all these trials for etrolizumab. And while there were hints of efficacy in UC, they weren't consistent. So I thought that this drug will get fully developed for ulcerative colitis. However, we do have some early data with the use of etrolizumab in Crohn's disease. This was a phase 3 induction cohort of etrolizumab in Crohn's disease, and the primary endpoint at week 14 was met against placebo, and we're still accumulating data. They're still recruiting patients for the second and third parts of the Bergamot study. So I suspect that sometime next year, we'll see more data about whether or not etrolizumab works in Crohn's disease. A brief mention about the anti-MAdCAM antibody. It actually has a name now. It's called Ontalimab, and I think I'm mispronouncing that. But this is a monoclonal antibody to MAdCAM1. And this is a study that was presented several years ago at DDW, and it's actually published. And in ulcerative colitis, some of the doses of this anti-MAdCAM antibody were significantly better than placebo. However, in Crohn's disease, this was a negative trial. This did not achieve statistical significance in Crohn's disease. And so studies are ongoing with this particular molecule. I want to shift gears and talk about a second class of therapy, which are the anti-IL-23 cytokines. Recall that ustekinumab blocks both the P40 and the P19. I'm sorry, the P40 subunit of both IL-12 and IL-23. These new drugs block P19 and therefore are more specific to IL-23. And there's actually 4 or potentially 5 molecules that are being developed. The first one we'll talk about is Brachicumab. This was a Crohn's disease trial, phase 2A, and you can see that this met the primary endpoint for CDAI response as well as CDAI remission. This was statistically significant. All of these IL-23s, the way these trials are designed, the drug is given IV loading dose, and then in the maintenance study, it's given sub-Q. And I think we've learned a lot about the pharmacokinetics, about biologics. So you'll see that all the IV induction doses are massive doses of drug, and then a much lower dose in maintenance. Here's another anti-IL-23, risenkizumab. This one is probably the furthest along for Crohn's disease right now. This was the phase 2 trial that was published in Lancet a few years ago, showing that it met all of the primary and secondary endpoints in induction. And we just saw press releases from the manufacturer of risenkizumab just a couple months ago that both phase 3 induction studies One was a combination of failures of conventional therapy and biologic therapy, and the other one was pure biologic failure patients. But you can see that in both of these trials, both loading doses of risenkizumab, and this was given every 4 weeks, and this was studied at week 12, were significantly better than placebo. So I suspect that we'll see the full presentations about this drug in some of the upcoming meetings, and we'll probably see the maintenance data for this drug later this year. And if that looks good, you could expect it to be approved perhaps a year from now by the FDA. And then mirikizumab is probably the IL-23 that's furthest along for ulcerative colitis. This was the phase 2 ulcerative colitis study. On the left, you'll see a figure showing that the middle dose of 200 milligram was significantly better than placebo for inducing clinical remission. And then in the maintenance trial, they studied 2 different doses and both looked good. There really wasn't a placebo. And you can see that endoscopic remission looked good. So this paper has already been published in gastroenterology. We saw a proof of concept, a phase 2 study in Crohn's disease as well. I apologize for the busyness of this slide, but you can see that several different doses of this drug were better than placebo for both inducing endoscopic response and endoscopic remission. And we'll probably be seeing both for Crohn's and for UC, mirikizumab is currently in phase 3 trials. And in fact, just last week, the manufacturer of mirikizumab put out a press release just last week saying that their phase 3 induction trial in ulcerative colitis was significant, but they didn't release any details about the numbers. So I suspect we'll hear about that at one of the upcoming meetings. And then the other anti-IL-23 is GIzelcumab. And this was an interesting trial that was presented at the fall meetings. And the reason this was interesting is not only was it a placebo-controlled trial, there was actually an active comparator arm with ustekinumab. So the green is placebo, and then the far column, the sort of the light blue is ustekinumab. And you can see that all 3 doses of GIzelcumab were better than placebo and were in the ballpark, at least in some cases numerically, not statistically better than ustekinumab. So I think the interesting thing about this was that they chose in a registrational trial to do a head-to-head with ustekinumab. Okay, so that's the anti-IL-23s. Let's talk about the selective Jack inhibitors. JAKs work by mediating the message between the cytokines and the nucleus. And so the JAK is on the bottom of the receptor of the cytokine, and then that activates the STATs, which then activate the nucleus to affect gene transcription. And then different combinations of JAKs are associated with different cytokine receptors. And recall that upanisidneb at low doses inhibits both JAK1 and JAK3, and at higher doses, it inhibits all 3 JAKs. Whereas some of the newer drugs like filgotinib and upanisidneb are probably more selective for JAK1, more preferential for JAK1 than the other JAKs. And that might explain some of the differences in the efficacy and the safety profile. So let's talk about some of these. Here's filgotinib, one of the selective JAK1s. This was a phase 2 trial in Crohn's disease that was published several years ago, showing that it was in fact a positive trial. Recall that for upanisidneb, the Crohn's trials were negative. And then here's some that more endoscopic data in detail, showing that there was a 25% endoscopic improvement by week 10. Here is filgotinib, the phase 3 in ulcerative colitis. They didn't even do a phase 2 in ulcerative colitis. They went right to phase 3. And this is showing, I apologize for, I think there was a formatting issue here, but this is showing basically the induction and maintenance. On the left is the week 10 data, and on the right is the week 58 data. But you can see that the 200 milligram dose of filgotinib is better than placebo in both the biologic naive and the biologic experienced patients. And then in maintenance, the 100 milligram was somewhat positive, but the 200 milligram was definitely positive. And so I suspect we're going to see more data come out about filgotinib in the near future. There is a phase 3 Crohn's trial going on that we haven't seen the results of yet. There's also an issue that has to be resolved by the FDA. There's concerns based on the preclinical data about testicular safety in men who receive filgotinib, and that's why they were kind of dose limited. They couldn't really study much beyond 200 milligrams. So we're going to need to learn more about that before we see more. This was some of the steroid-free maintenance data that's showing that the 200 milligram dose was significantly better than placebo at achieving steroid-free clinical remission for at least 6 months. The nice thing about filgotinib is that it doesn't seem to have as much of a zoster signal as tofacitinib did at the higher doses. And they also really haven't seen much of a signal for thromboembolism. And I'm going to skip that slide in the interest of time. Upanisidneb is the other JAK1 that's been studied in Crohn's disease. This was a phase 2 trial. This was published in Gastroenterology last year. And it showed that several different doses of upanisidneb were more effective than placebo. This was using an immediate release formulation that was BID. The current drug being studied is actually a delayed release formulation that's given once a day. So that's why the milligram doses here don't make sense compared to what you see more recently. Here's a phase 2 study in ulcerative colitis, also published earlier this year, showing that the higher doses of upanisidneb were better than placebo for achieving clinical remission and also endoscopic improvement. And then we just got two press releases from AbbVie in the last 3 or 4 months showing that both phase 3 induction studies in ulcerative colitis were positive. I suspect we'll see these be fully presented at meetings upcoming, and then again the maintenance data should come out sometime later this year. So potentially by next year we'll have 2 different JAK1 inhibitors approved for ulcerative colitis, and then later on maybe the Crohn's disease. This was an interesting gut restricted JAK molecule. This was very early phase 1 data. And the phase 2 is ongoing. We just don't have enough data yet to say, but it looks promising based on this very limited data. And then the final class of medications we'll talk about are the S1P receptor modulators. And these drugs work by affecting the way the lymphocytes leave the lymph nodes. And because of this S1P gradient, the lymphocytes, if you block that, the lymphocytes get trapped in the lymph nodes. There's some mild peripheral lymphopenia. And of course, this is reversible once you stop the drug, but this is the mechanism of action. Here's one study in ulcerative colitis with etrolyzumab, a phase 2 study that was published earlier, last year. And this showed endoscopic improvement at the higher dose as well as remission at the higher dose. And then ozanimod, which you probably have heard of in the past for phase 2 in ulcerative colitis, just came out with phase 3 of this past fall and showed that this drug was effective for multiple endpoints, both in the TNF exposed population and the TNF naive population. And this is the maintenance study, the 52-week data showing basically the same thing. It worked in both the bio-naive and the bio-experienced population. Multiple endpoints were met. Safety looks good. This is probably going to be a safe class of medications. This drug is actually on the market for MS, and it does not have a black box warning. So this is another promising class of medication. So to conclude, Etrolyzumab had mixed results for UC in the phase 3 trials, but the early data for Crohn's are promising. The anti-MAdCAM antibody was effective for UC, but not Crohn's in phase 2 trials. We've got 4 different anti-P19 antibodies, Brachicumab, risenkizumab, mirikizumab, and GIzelcam, and these were effective in phase 2 trials, and mirikizumab looked effective in UC. And then we have 2 oral selective JAK1 antagonists, Gotniv and upanisidneb, which were effective in both phase 2 of Crohn's and phase 2 and phase 3 of ulcerative colitis, and then ozanimod, effective for moderate to severe UC in phase 3, as well as etrolyzumab in phase 2. So the future is very bright. We've got a lot of drugs in the pipeline with different mechanisms of action, and this can only benefit our patients. And I thank you for your attention. Thanks.
Thank you, Dr. Edward. It was a wonderful presentation. It was a wonderful summary of all the newer drugs which are on the pipeline for the treatment of Crohn's disease and the IBD. It is a wonderful show by the PGI department. I always feel happy to be a part of it, which is my alma mater. Any questions? I don't find any questions as of now. One comment from my side is I feel myself to be in the pre-PPI era of peptic ulcer disease. I think the pre-PPI era was a tough time for treatment of peptic ulcer disease. We are almost in the same phase of treatment of IBD. Biologicals have changed the treatment of IBD in the latest season, and then the newer drugs probably will completely get the IBD under our control. I think Edward should agree with us. Your comments, sir, on this?
Well, I think there's a couple points. I think one thing is that I'm particularly excited about the oral drugs, because I think some of them, depending on their safety profiles, might have the opportunity to move up in the treatment algorithm in front of some of the biologics. And then the other comment is, and you sort of alluded to this, I think by combining drugs with different mechanisms of action, we may be able to really push the efficacy without compromising safety. So it is an exciting time in IBD drug development. We're still not at the point where we can say cure, but I'm feeling much more optimistic about our efficacy.
Thank you, Dr. Edward. I think you have given us the overview of the IBD in the future. Definitely, the more and more you meddle with the immune system, we are trying to trigger the infections, and more infections are likely to come up. Definitely, the future is the era, would be the era of the oral drugs, because they are going to be more easily available, safer, and also affordable compared to the parenteral drugs. I think the research in this field is going to help a lot of world population. Thank you very much, Loftus, for your lucid lecture, and we really enjoyed the lecture. Thank you very much.
Thank you. Thanks for having me.
Yeah. Over to you, Vishal.
Thank you so much, sir. Thank you, the chairpersons and the speaker, for a very, very, I would say, lucid session. And now